As you settle into this moment, wherever you find yourself, notice the quiet rhythm of your breathing. Air moves in and out without conscious effort, carrying oxygen to every cell, sustaining the intricate chemistry of life itself. Within you right now, thousands of chemical reactions are unfolding, a vast network of molecular interactions that keep you alive, aware, and present. Tonight, we explore the science of pharmacology, the study of how substances interact with living systems to produce change. This is not a journey through memorization or lists of medications, but rather an exploration of principles, of understanding how molecules become messengers, how chemistry becomes therapy, and how human ingenuity has learned to speak the language of cells. Pharmacology exists at the intersection of chemistry and biology, a field where the inanimate becomes purposeful, where carefully designed molecules travel through bloodstreams to find their destinations with remarkable precision. Think of pharmacology as the art of chemical conversation, where every drug is a word spoken in the body's native language, and every therapeutic effect is an answer to a question we have carefully posed. Throughout this exploration, we will move gently through layers of understanding, from the most fundamental concepts to the elegant complexity of how multiple systems coordinate their responses. We will discover that pharmacology is not simply about treating disease, but about understanding the body so deeply that we can whisper suggestions to its cells, nudging biological processes toward balance and health. The human body operates through chemical signals. Every thought, every heartbeat, every movement of nutrients across a membrane happens because molecules find each other, bind together, and trigger cascades of events. Pharmacology harnesses this truth. When we understand the chemical conversations already happening inside us, we can design new molecules that join these conversations. Molecules that can amplify signals that have grown too quiet, silence messages that have become too loud, or replace words that the body has forgotten how to speak. This is the fundamental premise upon which all of pharmacology rests, the recognition that life is chemistry and chemistry can be guided. Let us begin gently with the concept of a drug itself. In pharmacology, a drug is any chemical substance that produces a biological effect when introduced into a living system. This definition is beautifully broad. A drug might be a molecule extracted from a plant, something humans have used for thousands of years. It might be a synthetic compound, crafted in a laboratory through deliberate chemical design. It might be a naturally occurring substance in the body, reproduced and administered to supplement what nature provides. What makes something a drug is not its origin, but its action, its ability to change the behavior of cells, tissues, or organisms in predictable ways. Some drugs heal, some drugs harm, and many can do both depending on dose, timing, and context. Pharmacology studies all of these possibilities with equal curiosity. The story of pharmacology stretches back to the earliest human societies. Long before anyone understood molecules or receptors, healers knew that certain plants could ease pain, that others could reduce fever, and still others could alter consciousness. Willow bark for headaches, foxglove for heart troubles, opium poppies for pain. These were the original pharmacological tools, discovered through observation, trial, and the accumulated wisdom of generations. What has changed is not the fundamental truth that substances can affect the body, but our understanding of how and why. Modern pharmacology takes the observations of millennia and explains them in the language of molecular interaction. The same salicylic acid that ancient healers extracted from willow bark is now synthesized as aspirin, but its action on the body remains fundamentally the same, inhibiting specific enzymes that promote inflammation and pain. To understand how drugs work, we begin with the concept of a receptor. Imagine the surface of a cell as a vast landscape, its membrane dotted with millions of protein structures that extend outward like antennae, constantly sensing the chemical environment. These proteins are receptors, specialized molecules designed to recognize and bind to specific chemical signals. Each receptor has a shape, a three-dimensional architecture that allows it to embrace certain molecules while ignoring others. This is the lock and key principle of pharmacology, though the reality is more nuanced than this simple metaphor suggests. Receptors are not rigid locks, but dynamic structures that shift and change when they encounter the right molecule. When a drug binds to a receptor, it does not simply fit into a pre-existing space. It induces a conformational change, a subtle rearrangement of the protein structure that triggers a cascade of events inside the cell. Drugs that bind to receptors can do one of two things. They can activate the receptor, mimicking the natural signal and producing the same cellular response. These drugs are called agonists, molecules that speak the body's language with a native accent, saying the same things that natural messengers would say. Or drugs can bind to receptors without activating them, occupying the binding site and preventing natural signals from getting through. These are antagonists, molecules that block conversation, creating silence where there was once chemical dialogue. Both approaches have therapeutic value. Sometimes we need to amplify a signal that has become too weak, and we use an agonist. Sometimes we need to quiet a signal that has become too strong, and we use an antagonist. The art of pharmacology lies in knowing which conversation to enhance and which to silence. Consider the endogenous ligands, the body's own signaling molecules. These are the native words in the chemical language your cells speak. Neurotransmitters like dopamine, serotonin, and acetylcholine. Hormones like insulin, adrenaline, and cortisol. Each of these molecules is produced by the body for specific purposes, released at specific times to specific targets. They bind to their receptors with exquisite selectivity, triggering responses that range from the contraction of a muscle fiber to the alteration of mood and perception. Pharmacology studies these endogenous ligands intensely because understanding the body's native signals is the foundation for designing drugs that can enhance, replace, or block them. Many of the most important medications in use today are simply synthetic versions of these natural molecules or close chemical relatives that bind to the same receptors with similar or modified effects. The relationship between drug concentration and effect is one of the most fundamental concepts in pharmacology, described by the dose-response curve. Imagine graphing the amount of drug administered against the intensity of the biological response it produces. At very low doses, there may be no detectable effect. The drug molecules are too few. Their encounters with receptors too rare to produce noticeable change. As the dose increases, responses begin to appear, subtle at first, then more pronounced. Eventually, a dose is reached where the response is maximal, where increasing the amount of drug no longer produces greater effect because all available receptors are occupied. All possible cellular machinery is engaged. This curve has a characteristic shape, typically sigmoidal, an S-shaped pattern that reflects the saturable nature of biological systems. Understanding this relationship allows us to predict therapeutic doses, the amounts needed to produce benefit, and toxic doses, the amounts that produce harm. Potency and efficacy are two distinct but often confused properties of drugs. Potency refers to the amount of drug needed to produce a given effect. A highly potent drug achieves its therapeutic action at low doses, while a less potent drug requires higher doses to achieve the same result. Efficacy, by contrast, refers to the maximum effect a drug can produce, regardless of dose. A drug might be very potent, but have low efficacy, producing its effects at tiny doses, but never achieving a very strong maximum response. Another drug might have low potency, but high efficacy, requiring large doses, but capable of producing profound effects once those doses are reached. Both properties matter in clinical medicine. Potency determines practical considerations like pill size and frequency of dosing. Efficacy determines whether a drug can achieve the therapeutic goal at all. A highly potent drug is not necessarily better than a less potent one. What matters is whether it can produce the desired effect safely and consistently. The therapeutic index is a measure of a drug's safety margin, the relationship between the dose that produces therapeutic effects and the dose that produces toxic effects. Imagine two dose-response curves plotted side by side, one for the desired therapeutic effect and one for a toxic effect. The distance between these curves, the separation between benefit and harm, is the therapeutic index. A drug with a wide therapeutic index is forgiving. Therapeutic doses are far below toxic doses, leaving room for individual variation and dosing errors. A drug with a narrow therapeutic index is unforgiving. The dose that heals is dangerously close to the dose that harms, requiring careful monitoring and precise dosing. Many life-saving medications have narrow therapeutic indices. Drugs like warfarin for blood clotting, lithium for mood disorders, and digoxin for heart failure. These medications demand respect, careful calculation, and frequent measurement of blood levels to ensure they remain in the narrow window where benefit outweighs risk. Now we turn to pharmacokinetics, the study of what the body does to a drug, how drugs move through biological systems over time. Pharmacokinetics is often summarized by four processes: absorption, distribution, metabolism, and excretion, sometimes abbreviated as ADME. Each of these processes determines how much drug reaches its target, how long it stays there, and how the body ultimately removes it. Together, they determine the practical reality of medication use, how often doses need to be given, what route of administration works best, and which patients might need adjusted doses based on their unique physiology. Absorption is the journey from the site of administration into the bloodstream. When you swallow a tablet, the drug must first dissolve in the fluids of your digestive tract, then cross the epithelial barrier of the intestinal wall to enter the blood vessels that will carry it throughout your body. This process is influenced by many factors: the chemical properties of the drug itself, whether it dissolves easily in water or fat, whether it is stable in the acidic environment of the stomach, the presence of food in the digestive tract, which can slow absorption or enhance it depending on the drug's characteristics, the health of the intestinal lining, which can be compromised by disease or inflammation. Not all of an orally administered drug reaches the bloodstream intact. Some drugs are broken down by stomach acid, others by enzymes in the intestinal wall, and still others are metabolized by the liver before they even have a chance to circulate throughout the body. This first-pass metabolism can dramatically reduce the amount of active drug available, sometimes making oral administration impractical. Different routes of administration bypass or modify these barriers. Intravenous injection delivers drug directly into the bloodstream, achieving complete absorption instantaneously with no barriers to cross and no losses to first-pass metabolism. Intramuscular or subcutaneous injection places drug into tissue from which it must diffuse into nearby blood vessels, a process that is slower than intravenous but faster and more reliable than oral absorption. Inhalation delivers drug to the vast surface area of the lungs, where thin membranes separate air from blood, allowing rapid absorption with minimal degradation. Topical application aims for local effects, with minimal absorption into the bloodstream, though some drugs applied to skin will eventually enter systemic circulation. Each route has advantages and disadvantages, chosen based on the desired speed of onset, the drug's stability, and the clinical situation. Distribution describes how drugs spread throughout the body once they reach the bloodstream. Blood is the primary highway, a circulatory system that touches every tissue, delivering oxygen, nutrients, and whatever drugs we introduce. But distribution is not uniform. Different tissues receive blood at different rates. The brain and kidneys are richly perfused, receiving a large proportion of cardiac output, while fat tissue and bone receive relatively less. Drugs carried by blood will initially distribute to well-perfused organs, where concentrations rise quickly, then slowly redistribute to less perfused tissues over time. The chemical properties of a drug determine which tissues it can enter. Lipophilic drugs, those that dissolve well in fat, can cross cell membranes easily, entering tissues throughout the body, including the brain. Hydrophilic drugs, those that prefer aqueous environments, tend to stay in the bloodstream and extracellular fluid, having difficulty crossing the fatty barriers of cell membranes. Volume of distribution is a theoretical concept that quantifies how widely a drug spreads through the body. It is calculated by comparing the total amount of drug in the body to the concentration measured in blood. A drug with a small volume of distribution stays mostly in the bloodstream, while a drug with a large volume of distribution spreads into tissues, sometimes binding there or accumulating in fat stores. This number helps predict how quickly drug levels will fall when dosing stops, and whether dialysis can effectively remove a drug in cases of overdose. Drugs with very large volumes of distribution have spread so widely into tissues that the amount in blood represents only a tiny fraction of the total body load, making them difficult to remove by filtering blood. Protein binding is another factor that affects distribution. Many drugs bind to proteins in the blood, especially albumin and alpha-1 acid glycoprotein. When bound to protein, drug molecules are too large to cross capillary walls, effectively trapped in the bloodstream, unable to reach their sites of action or elimination. Only the free, unbound fraction of drug can leave the blood to interact with receptors or be metabolized. This creates an equilibrium. As free drug leaves the bloodstream, bound drug dissociates from proteins to maintain the balance. Protein binding acts as a reservoir, a temporary storage system that prolongs drug presence in the body and buffers against rapid changes in free drug concentration. In patients with low albumin levels, due to malnutrition or liver disease, the free fraction of highly protein-bound drugs may be elevated, leading to enhanced effects or toxicity at standard doses. Metabolism is the body's method of transforming drugs into forms that can be more easily eliminated. The liver is the primary site of drug metabolism, a chemical processing plant that contains enzymes capable of modifying an enormous variety of molecular structures. These enzymes, particularly the cytochrome P450 family, catalyze reactions that make drugs more water-soluble, less able to cross membranes, more likely to be recognized by excretion systems. Metabolism usually inactivates drugs, converting them from active forms to inactive metabolites. But sometimes metabolism activates prodrugs, substances that are given in inactive form and converted by the body into active compounds. And sometimes metabolism produces active metabolites, breakdown products that have their own pharmacological effects, extending or modifying the action of the original drug. The cytochrome P450 enzymes are the workhorses of drug metabolism, a family of related proteins that can oxidize, reduce, and otherwise modify chemical structures. These enzymes show genetic variation. Different people inherit different versions that work with varying efficiency. This pharmacogenomic variability means that identical doses of the same drug can produce different blood levels in different patients. Some people metabolize certain drugs very rapidly, clearing them before therapeutic levels can be sustained, while others metabolize the same drugs slowly, accumulating higher levels and greater risk of toxicity. Understanding these genetic differences is becoming increasingly important in personalized medicine, allowing clinicians to predict which patients need higher or lower doses, or which drugs might work better based on an individual's metabolic capacity. Enzyme induction and inhibition are phenomena where one drug alters the metabolism of another. Some drugs, when taken regularly, induce the liver to produce more metabolic enzymes, increasing the capacity to break down not only that drug, but others as well. This can decrease the effectiveness of medications metabolized by those enzymes, including oral contraceptives, anticoagulants, and many others. Other drugs inhibit metabolic enzymes, reducing the liver's ability to process certain medications, potentially causing accumulation and toxicity. These drug-drug interactions are a major consideration in pharmacology, particularly in patients taking multiple medications. The liver's metabolic capacity is finite, and when multiple drugs compete for the same enzymes, the rates at which each is processed can change unpredictably. Excretion is the final step. Removal of drugs and their metabolites from the body. The kidneys are the primary route of excretion, filtering blood to produce urine and carrying away water-soluble substances. Drugs and metabolites that have been made sufficiently hydrophilic by liver metabolism are readily excreted in urine, while highly lipophilic substances are reabsorbed from the kidney tubules back into the bloodstream, recycled rather than eliminated. Renal function, therefore, has enormous impact on drug elimination. Patients with kidney disease accumulate drugs, normally excreted renally, requiring dose adjustments to prevent toxicity. Creatinine clearance, a measure of kidney filtration capacity, is routinely used to guide dosing in these patients. Other routes of excretion include bile, where the liver secretes drugs and metabolites into the digestive tract, sometimes to be reabsorbed in a cycle called enterohepatic recirculation, other times to be eliminated in feces. Lungs excrete volatile substances, which is why breath can smell of alcohol or garlic. Sweat, saliva, and breast milk are minor routes that matter in specific contexts, particularly the last for nursing infants who may receive small amounts of maternal medications. The mammary glands concentrate certain drugs, and some medications contraindicate breastfeeding because of potential harm to the infant. Half-life is the time it takes for the concentration of a drug in blood to decrease by half. This single number captures the combined effects of distribution, metabolism, and excretion. A short half-life means the body clears the drug quickly, requiring frequent dosing to maintain therapeutic levels. A long half-life allows infrequent dosing, but also means the drug persists in the body long after administration stops, which can be problematic if adverse effects develop. After starting a drug with a long half-life, it takes several half-lives to reach steady state, the point where the amount administered with each dose equals the amount eliminated and blood levels stabilize. Similarly, after stopping the drug, it takes several half-lives for the body to eliminate it completely. This is why some medications require days to reach full effectiveness and days to wash out after discontinuation. Loading doses and maintenance doses reflect these kinetic realities. For drugs with long half-lives, waiting for steady state may be impractical in acute situations. A loading dose, larger than the maintenance dose, can rapidly achieve therapeutic levels, after which smaller maintenance doses sustain those levels. This approach is common with antibiotics in serious infections, anticoagulants in acute thrombosis, and antiarrhythmics in emergencies. The loading dose fills the volume of distribution quickly, while maintenance doses replace only what is eliminated, maintaining equilibrium. Clearance is the volume of blood completely cleared of drug per unit time, a rate that reflects the combined efficiency of all elimination processes. Total body clearance is the sum of renal clearance, hepatic clearance, and any other routes of elimination. This parameter determines the maintenance dose needed to sustain a desired concentration at steady state. Higher clearance requires higher doses to maintain the same blood level, while reduced clearance from kidney or liver disease necessitates dose reduction. Bioavailability quantifies the fraction of an administered dose that reaches systemic circulation in active form. For intravenous drugs, bioavailability is by definition 100%. All of the dose enters the blood. For orally administered drugs, bioavailability is often less than 100% due to incomplete absorption and first-pass metabolism. This is why oral doses are often larger than intravenous doses of the same drug, compensation for the fraction lost before reaching circulation. Bioavailability can vary between different formulations of the same drug, between generic and brand name versions, and between different manufacturers, though regulatory standards aim to minimize these differences. Now we shift from pharmacokinetics to pharmacodynamics, from what the body does to the drug to what the drug does to the body. Pharmacodynamics describes the biochemical and physiological effects of drugs, the mechanisms by which molecules produce change in living systems. At the heart of pharmacodynamics is the drug-receptor interaction, but this interaction is just the beginning of a cascade that can amplify a single binding event into widespread cellular and systemic effects. Receptors are classified into families based on their structure and mechanism of action. Ligand-gated ion channels are receptors that form pores in cell membranes, opening when the right molecule binds, allowing ions to flow across the membrane and changing the electrical properties of the cell. These receptors mediate fast synaptic transmission in the nervous system, where neurotransmitters like acetylcholine or GABA bind to receptors on the postsynaptic membrane, opening channels that depolarize or hyperpolarize the cell within milliseconds. G-protein-coupled receptors are the largest family. serpentine proteins that span the membrane 7 times, linked on the intracellular side to G proteins that activate second messenger systems when the receptor is stimulated. These receptors mediate slower, more sustained responses, modulating cellular metabolism, gene expression, and long-term changes in cell behavior. Enzyme-linked receptors have intrinsic enzymatic activity or are directly coupled to enzymes, often kinases that phosphorylate other proteins to propagate signals. Intracellular receptors are found inside cells, typically in the cytoplasm or nucleus, binding to lipophilic drugs that can cross membranes. These receptors often regulate gene transcription directly. Signal transduction, the process by which receptor binding leads to cellular response, involves complex cascades of molecular events. A drug binds to a receptor on the cell surface. The receptor changes shape and activates a G protein. The G protein activates or inhibits an enzyme that produces a second messenger like cyclic AMP. The second messenger activates protein kinases that phosphorylate target proteins, and these phosphorylated proteins alter cell function. This cascade amplifies the signal. A single receptor binding event can generate thousands of second messenger molecules, each capable of activating multiple kinases, each kinase phosphorylating multiple targets. The result is that tiny concentrations of drug can produce profound cellular effects. Selectivity is a crucial concept in pharmacodynamics. No drug is perfectly selective. All drugs bind to multiple targets with varying affinity. The therapeutic value of a drug depends on binding more strongly to the desired target than to off-target sites. Selectivity is relative. At low doses, a drug may interact primarily with its intended receptor, producing therapeutic effects, while at higher doses, it begins to interact with other receptors, producing side effects. This is why dose matters so profoundly, not only for the magnitude of the desired effect, but for the emergence of unwanted effects as concentrations rise. Agonists can be full or partial. A full agonist produces the maximum possible response when it occupies all receptors. It has high efficacy. A partial agonist, even when occupying all receptors, produces less than the maximum response. It has lower intrinsic activity. Partial agonists have interesting properties. In the presence of a full agonist, they act as competitive antagonists, occupying receptors but producing less response, thereby reducing the overall effect. In the absence of a full agonist, they produce a modest response, providing some activation. This makes partial agonists useful in situations where we want to maintain baseline receptor activity while preventing excessive stimulation. Inverse agonists are molecules that bind to receptors and produce the opposite effect of agonists. Some receptors have constitutive activity, a baseline level of signaling even without any ligand bound. Inverse agonists reduce this baseline activity below normal levels, actively suppressing receptor signaling rather than simply blocking it. The distinction between antagonists and inverse agonists matters when receptors have high constitutive activity. An antagonist would reduce signaling to baseline, while an inverse agonist reduces it below baseline. Competitive antagonists bind to the same site on the receptor as the agonist, competing for occupancy. If enough antagonist is present, it can be overcome by increasing the concentration of agonist, shifting the dose-response curve to the right, but not changing the maximum response achievable. Non-competitive antagonists bind to a different site or bind irreversibly, and their effects cannot be overcome simply by adding more agonist. These antagonists reduce the maximum response achievable. fundamentally limiting what the receptor system can do even with unlimited agonist present. Desensitization and tolerance are phenomena where repeated or prolonged exposure to a drug reduces its effectiveness over time. Receptors can become less responsive through several mechanisms. They may be internalized, removed from the cell surface, and sequestered inside, reducing the number available for drug binding. Signaling pathways downstream of the receptor may be attenuated, with negative feedback mechanisms reducing the cascade's efficiency. The body may upregulate compensatory mechanisms that oppose the drug's effects. The result is that over time, higher doses are needed to achieve the same response, or the response diminishes even at constant doses. Tolerance develops at different rates for different drugs and different effects. Sometimes the therapeutic effect is maintained while tolerance develops to side effects, a favorable situation. Other times, tolerance to therapeutic effects develops faster, requiring escalating doses. Sensitization is the opposite phenomenon, where repeated exposure enhances response. This is less common but occurs with some drugs, particularly certain stimulants, where previous exposure makes the nervous system more reactive to subsequent doses. The mechanisms involve lasting changes in neuronal excitability, receptor expression, or synaptic strength. Tachyphylaxis is rapid tolerance, a diminished response that develops within minutes to hours rather than days to weeks. It often results from depletion of neurotransmitter stores or rapid receptor desensitization, and it resolves relatively quickly once drug administration stops, allowing stores to replenish and receptors to resensitize. Drug interactions occur when one drug alters the effect of another. Pharmacokinetic interactions involve changes in absorption, distribution, metabolism, or excretion. One drug affecting how much of another drug reaches its site of action. Pharmacodynamic interactions involve drugs acting on the same or related receptor systems, producing additive, synergistic, or antagonistic effects. Additive effects occur when two drugs produce the same type of response through independent mechanisms and their effects sum. Synergistic effects occur when two drugs produce a combined effect greater than the sum of their individual effects, often because they enhance each other's mechanisms. Antagonistic effects occur when one drug opposes the action of another, reducing or nullifying its effect. The concept of therapeutic drug monitoring emerges from the recognition that for some medications, the relationship between dose and blood concentration is unpredictable, and the relationship between blood concentration and effect is clearer than between dose and effect. For these drugs, measuring blood levels guides dosing decisions. Drugs with narrow therapeutic indices, significant pharmacokinetic variability, and clear concentration-effect relationships are candidates for monitoring. The timing of blood sampling matters. Trough levels drawn just before the next dose reflect the minimum concentration during the dosing interval and help ensure levels don't fall below the therapeutic range, while peak levels drawn after administration help ensure levels don't exceed the toxic range. We now turn our attention to the major drug classifications, beginning with principles rather than specific names, understanding the categories by their mechanisms and therapeutic roles. Pharmacology organizes drugs into classes based on shared properties, either the receptors they target, the physiological systems they affect, or the therapeutic purposes they serve. Each class represents a conversation the drug can have with the body, a particular way of influencing cellular behavior toward clinical goals. Autonomic pharmacology concerns drugs that affect the autonomic nervous system, the part of the nervous system that regulates involuntary functions, heart rate, blood pressure, digestion, breathing, and more. The autonomic system has two divisions, sympathetic and parasympathetic, often described as fight or flight versus rest and digest. Sympathetic activation prepares the body for action, increasing heart rate and blood pressure, dilating airways, mobilizing energy stores, shunting blood to muscles. Parasympathetic activation promotes recovery and conservation, slowing heart rate, promoting digestion, constricting pupils, conserving energy. These two branches usually oppose each other, providing balanced regulation of organ function. Drugs that affect autonomic function can mimic or block either branch, producing profound systemic effects. Cholinergic drugs affect acetylcholine signaling, the neurotransmitter of the parasympathetic system and the somatic motor system. Cholinergic agonists activate acetylcholine receptors, which come in two main types: muscarinic receptors found on organs innervated by parasympathetic nerves, and nicotinic receptors found at neuromuscular junctions and autonomic ganglia. Muscarinic agonists slow the heart, increase gastrointestinal motility, constrict pupils, stimulate secretions. These effects can be therapeutic in conditions like urinary retention or glaucoma, where increasing smooth muscle contraction or secretions is beneficial. Nicotinic agonists are less commonly used therapeutically because their effects are more difficult to control, though nicotine itself is a well-known example, stimulating then desensitizing nicotinic receptors in the brain and periphery. Anticholinergic drugs block acetylcholine receptors, producing effects opposite to cholinergic activation. Muscarinic antagonists are widely used, reducing secretions, relaxing smooth muscle, increasing heart rate, dilating pupils. They treat conditions from asthma to motion sickness to overactive bladder. The side effects of anticholinergics are predictable extensions of their mechanism: dry mouth from reduced salivation, blurred vision from impaired accommodation, constipation from reduced gut motility, urinary retention from bladder relaxation, and in high doses, confusion and delirium from effects on the central nervous system. Cholinesterase inhibitors represent an indirect approach to enhancing cholinergic signaling. Instead of activating receptors directly, they inhibit the enzyme acetylcholinesterase, which normally breaks down acetylcholine in the synapse. With the enzyme inhibited, acetylcholine accumulates, prolonging and intensifying its effects. These drugs are used to treat myasthenia gravis, a condition where neuromuscular transmission is impaired, and Alzheimer's disease, where cholinergic neurons degenerate. The side effects reflect excessive cholinergic stimulation, salivation, lacrimation, urination, defecation, sometimes remembered by the mnemonic sludge, adding bronchospasm and bradycardia to complete the picture of cholinergic excess. Adrenergic drugs affect the sympathetic nervous system, which uses norepinephrine and epinephrine as neurotransmitters. Adrenergic receptors are divided into alpha and beta subtypes, each with further subdivisions. Alpha-1 receptors are found on vascular smooth muscle. Their activation causes vasoconstriction, raising blood pressure. Alpha-2 receptors are found presynaptically. Their activation inhibits further norepinephrine release, a negative feedback mechanism. Beta-1 receptors are found primarily in the heart. Their activation increases heart rate and contractility. Beta-2 receptors are found in bronchial smooth muscle and other tissues. Their activation causes bronchodilation and metabolic effects. Beta-3 receptors are found in adipose tissue involved in lipolysis and thermogenesis. Sympathomimetic drugs mimic sympathetic activation. They are adrenergic agonists. Non-selective agonists like epinephrine activate all receptor types, producing a coordinated sympathetic response useful in emergencies like anaphylaxis or cardiac arrest. Selective agonists target specific receptor subtypes to achieve more focused effects. Beta-2 selective agonists are used as bronchodilators in asthma, relaxing airway, smooth muscle without excessive cardiac stimulation. Though selectivity is relative and some cardiac effects occur at higher doses. Alpha-1 agonists are used as nasal decongestants, constricting blood vessels in nasal mucosa to reduce swelling. Adrenergic antagonists block sympathetic signaling. Alpha-1 blockers cause vasodilation, lowering blood pressure, and relax smooth muscle in the prostate, improving urinary flow in benign prostatic hyperplasia. Beta blockers are among the most widely used medications, blocking beta-1 receptors in the heart to slow heart rate and reduce contractility, lowering blood pressure and decreasing myocardial oxygen demand. They are used for hypertension, angina, heart failure, and arrhythmias. Non-selective beta blockers block both beta-1 and beta-2 receptors, the latter causing potential bronchoconstriction in susceptible individuals, which is why cardioselective beta-1 blockers are often preferred, though again selectivity is dose-dependent and relative. The interplay between sympathetic and parasympathetic tone creates a dynamic balance that pharmacology can shift. Blocking one system tips the balance toward the other, producing effects that are the algebraic sum of reduced activity in one branch and unopposed activity in the other. Understanding this balance allows prediction of drug effects even when mechanisms are indirect. As we reach a natural pause in our exploration, notice again your breathing, perhaps slightly deeper now as you've read about the systems that regulate it. The autonomic nervous system we've discussed continues its work within you, adjusting heart rate to your body's needs, regulating blood flow without conscious thought, maintaining the delicate equilibrium that keeps you stable. Pharmacology is the science of gently influencing these balances, of speaking to the body in its own chemical language. We have laid foundations, defined terms, explored principles that underlie all drug action. The concepts of receptors and signaling, of absorption and elimination, of agonism and antagonism. These are the vocabulary we will use as we continue to explore specific drug classes and their therapeutic applications. The journey continues, building understanding layer upon careful layer, always grounded in the recognition that every drug is a chemical conversation, and every therapeutic effect is the body's eloquent response. We return now to our exploration of pharmacology, carrying with us the foundational concepts we have established, the language of receptors and ligands, the principles of pharmacokinetics and pharmacodynamics, the understanding that drugs are chemical messages spoken in the body's native vocabulary. With these foundations secure, we can now venture deeper into the landscape of drug classifications, exploring how different classes of medications interact with specific physiological systems to produce therapeutic effects. Each system we encounter reveals new dimensions of how carefully designed molecules can influence biological processes, always working within the constraints and opportunities that evolution has provided. Cardiovascular pharmacology addresses one of the body's most vital systems, the network of heart and vessels that delivers oxygen and nutrients to every cell. The cardiovascular system operates through electrical signals that coordinate cardiac contraction. mechanical forces that propel blood through vessels, and chemical signals that regulate vascular tone and blood volume. Drugs that affect this system can influence any of these components, changing heart rate and rhythm, altering the force of cardiac contraction, dilating or constricting blood vessels, adjusting blood volume, or modifying the composition of blood itself. Antihypertensive medications lower blood pressure through diverse mechanisms, reflecting the multiple systems that regulate vascular tone and blood volume. Diuretics increase urine production, reducing blood volume and thereby decreasing the pressure within the vascular system. Think of the circulatory system as a closed hydraulic circuit. Reducing the volume of fluid within that circuit necessarily reduces the pressure, much as releasing water from a filled water balloon reduces the tension in its walls. Different classes of diuretics act at different points along the kidney tubule, each influencing which ions are excreted and retained, each with distinct effects on electrolyte balance. Thiazide diuretics act in the distal tubule, inhibiting sodium reabsorption and causing increased excretion of sodium and water. The body follows sodium. Where sodium goes, water follows. And by preventing sodium reabsorption, thiazides ensure that both are lost in urine. The effect is modest but sustained, making thiazides suitable for chronic blood pressure management. Loop diuretics act in the thick, ascending limb of the loop of Henle, a segment crucial to the kidney's concentrating mechanism. By blocking sodium reabsorption here, loop diuretics produce profound diuresis, capable of removing large volumes of fluid in patients with heart failure or edema. Their potency makes them essential in acute situations, but also means they can disturb electrolyte balance significantly. Potassium-sparing diuretics act in the collecting duct, either by blocking aldosterone receptors or by directly closing sodium channels. They produce modest diuresis but preserve potassium, which other diuretics tend to waste. This makes them useful in combination with other diuretics to maintain electrolyte balance. Calcium channel blockers reduce blood pressure by preventing calcium entry into smooth muscle cells in vessel walls. Smooth muscle contraction requires calcium. When calcium channels are blocked, the muscle cannot contract as forcefully and vessels dilate. The resulting decrease in vascular resistance lowers blood pressure and reduces the workload on the heart. Different calcium channel blockers have varying selectivity for vascular smooth muscle versus cardiac muscle. Some primarily dilate vessels with minimal cardiac effects, useful for hypertension and angina. Others affect cardiac tissue more significantly, slowing heart rate and reducing contractility, useful for rhythm disorders as well as blood pressure control. Angiotensin-converting enzyme inhibitors, commonly called AC inhibitors, block the formation of angiotensin II, a powerful vasoconstrictor and stimulator of aldosterone release. The renin-angiotensin-aldosterone system is a hormonal cascade that raises blood pressure in response to low renal perfusion. Renin, released by the kidneys, converts angiotensinogen to angiotensin I, which ACE then converts to angiotensin II. By inhibiting this conversion, ACE inhibitors prevent the formation of angiotensin II, reducing vasoconstriction and decreasing aldosterone-mediated sodium retention. The result is vasodilation and modest diuresis, lowering blood pressure through two complementary mechanisms. ACE inhibitors also reduce the breakdown of bradykinin, a vasodilator, which contributes to their blood pressure lowering effect, but also causes a characteristic dry cough in some patients as bradykinin accumulates in the lungs. Angiotensin receptor blockers, or ARBs, achieve similar results through a different mechanism, blocking the receptors where angiotensin II exerts its effects rather than blocking its formation. This produces comparable blood pressure reduction without affecting bradykinin levels, avoiding the cough associated with ACE inhibitors. Both ACE inhibitors and ARBs have protective effects beyond blood pressure reduction, particularly in patients with diabetes or heart failure, where they slow the progression of kidney disease and cardiac remodeling. Beta blockers, which we introduced earlier, lower blood pressure primarily by reducing cardiac output. By blocking beta-1 receptors in the heart, they decrease heart rate and contractility, meaning less blood is pumped per minute. Over time, they also reduce renin release from the kidneys, providing an additional mechanism for blood pressure reduction. The diverse benefits of beta blockers extend beyond hypertension to include treatment of angina, where reducing cardiac workload decreases oxygen demand, and heart failure, where paradoxically, reducing the heart's work allows it to recover and remodel more favorably. Alpha blockers, as mentioned before, dilate blood vessels by blocking alpha-1 receptors on vascular smooth muscle. While effective for blood pressure reduction, they can cause orthostatic hypotension, a drop in blood pressure upon standing, as the body's normal reflex vasoconstriction is impaired. This side effect limits their use as primary antihypertensives, but makes them valuable for patients with both hypertension and urinary symptoms from prostatic enlargement, as the same receptors mediate smooth muscle contraction in the prostate. Vasodilators directly relax vascular smooth muscle through various mechanisms. Some open potassium channels, hyperpolarizing the muscle cell and making contraction more difficult. Others donate nitric oxide, the endogenous vasodilator that smooth muscle normally responds to as a signal to relax. These drugs produce potent vasodilation but often trigger reflex tachycardia as the body attempts to compensate for falling blood pressure by increasing heart rate, which can limit their usefulness unless combined with other agents that blunt this reflex. Antianginal medications relieve chest pain caused by inadequate oxygen delivery to the heart muscle. Nitrates are classic antianginal drugs, dilating veins more than arteries, reducing the amount of blood returning to the heart, and thereby reducing the heart's workload and oxygen demand. They also dilate coronary arteries, potentially improving blood flow to ischemic regions, though their primary benefit comes from reducing cardiac work. Nitrates are used both for acute anginal episodes, administered sublingually for rapid absorption, and for prevention in longer-acting oral or transdermal formulations. Tolerance develops with continuous exposure, which is why nitrate regimens typically include a nitrate-free interval each day, allowing receptors to resensitize. Beta blockers serve as antianginal agents by reducing myocardial oxygen demand. Slowing heart rate gives the heart longer diastolic filling times when coronary perfusion occurs, and reducing contractility decreases the work the muscle performs. Calcium channel blockers provide antianginal benefit through coronary vasodilation and, for some agents, reduction in cardiac workload. The choice among these classes depends on individual patient factors, heart rate, blood pressure, presence of other conditions, and specific symptoms. Antiarrhythmic drugs manage abnormal heart rhythms, a complex challenge because the heart's electrical system is intricate, and many factors can disturb it. Arrhythmias can arise from abnormal impulse formation where pacemaker cells fire too rapidly or ectopic sites generate competing rhythms, or from abnormal impulse conduction, where electrical signals travel through aberrant pathways or encounter blocks that disrupt normal propagation. Antiarrhythmics are classified by their predominant mechanism. Though many drugs affect multiple aspects of cardiac electrophysiology, Class I antiarrhythmics block sodium channels, slowing the rate at which action potentials rise and propagate. By reducing the speed of electrical conduction, they can suppress rapid arrhythmias and break reentrant circuits, where electrical impulses chase their own tails through loops of cardiac tissue. Subclasses differ in their binding kinetics and effects on action potential duration. Class II antiarrhythmics are beta blockers, which slow heart rate and reduce the automaticity of pacemaker cells. Class III antiarrhythmics prolong action potential duration by blocking potassium channels, extending the refractory period and making it harder for premature beats to propagate. Class IV antiarrhythmics are calcium channel blockers that slow conduction through the AV node, useful for controlling ventricular rate in atrial arrhythmias. Each class has specific indications and risks. Some antiarrhythmics can paradoxically cause arrhythmias, a proarrhythmic effect that reflects the delicate balance of cardiac electrical activity and the difficulty of suppressing abnormal rhythms without disturbing normal ones. The use of antiarrhythmics requires careful assessment of risk versus benefit, with many patients now managed through non-pharmacological interventions like ablation or device therapy when appropriate. Drugs affecting hemostasis interact with the blood's clotting system, a complex cascade designed to seal vascular injuries while maintaining blood fluidity. The clotting cascade involves multiple proteases that activate sequentially, amplifying the initial signal until fibrin strands form a mesh that traps blood cells and creates a clot. Platelets contribute by adhering to damaged vessel walls, aggregating with each other, and providing surfaces where clotting factors concentrate. Endogenous anticoagulant and fibrinolytic systems counterbalance clotting, ensuring that coagulation remains localized and temporary. Pharmacological intervention can enhance or suppress any of these components. Anticoagulants prevent clot formation by interfering with the clotting cascade. Heparin and related compounds enhance the activity of antithrombin, an endogenous inhibitor of clotting factors. By binding to antithrombin, heparin causes a conformational change that accelerates its inhibition of thrombin and other factors by orders of magnitude. Unfractionated heparin is a mixture of different-sized polysaccharide chains, administered intravenously or subcutaneously, with effects that are immediate but require monitoring because response varies between individuals. Low molecular weight heparins are smaller fragments with more predictable pharmacokinetics, allowing fixed dosing without routine monitoring. Both work immediately upon administration, making them valuable in acute situations like pulmonary embolism or acute coronary syndromes. Warfarin inhibits vitamin K epoxide reductase, an enzyme necessary for recycling vitamin K, which is required for the synthesis of several clotting factors. By depleting functional vitamin K, warfarin reduces the production of these factors, decreasing the blood's ability to clot. The effect takes days to develop as existing clotting factors are gradually cleared and replaced with non-functional versions. Warfarin's anticoagulant effect must be monitored through blood tests measuring the International Normalized Ratio, or INR, because response varies based on genetics, diet, and drug interactions. Many foods and medications affect warfarin metabolism or vitamin K availability, requiring vigilant monitoring and dose adjustment. Direct oral anticoagulants, or DOACs, represent a newer approach, directly inhibiting specific clotting factors, either thrombin or factor XA, without requiring cofactors like antithrombin. These drugs have more predictable pharmacokinetics than warfarin, allowing fixed dosing without routine monitoring. They act quickly and clear relatively quickly, making them convenient, but also requiring adherence since missed doses leave patients unprotected. Different DOACs have different half-lives and routes of elimination, which influences their use in patients with kidney or liver disease. Antiplatelet agents prevent platelet aggregation, the process by which platelets stick together to form the initial plug at sites of vascular injury. Aspirin irreversibly inhibits cyclooxygenase, an enzyme platelets use to produce thromboxane A2, a powerful promoter of platelet aggregation. Since platelets lack nuclei and cannot synthesize new enzyme, aspirin's effect lasts the lifetime of the platelet, about 7 to 10 days. Even low doses of aspirin can effectively suppress platelet function, and its use reduces the risk of heart attack and stroke in appropriate populations. Other antiplatelet agents block ADP receptors or glycoprotein IIB3A receptors on platelet surfaces, preventing the signaling and structural changes required for aggregation. These are often used in combination with aspirin in high-risk patients or after procedures like coronary stenting. Thrombolytic drugs actively dissolve existing clots by activating plasminogen, converting it to plasmin, an enzyme that degrades fibrin. These drugs are used in acute situations like ischemic stroke or massive pulmonary embolism, where rapid restoration of blood flow is critical. The risk is bleeding, since activating the fibrinolytic system systemically can cause degradation of clots that are serving useful hemostatic functions. Timing is crucial, as thrombolytics are most effective when given early, and contraindications such as recent surgery or bleeding risk make them unsuitable for many patients. The balance between clotting and bleeding is delicate, and drugs that affect hemostasis require respect for both their benefits and risks. Monitoring, attention to drug interactions, and careful patient selection are essential to using these medications safely. Lipid-lowering drugs address elevated cholesterol and triglycerides, risk factors for atherosclerotic cardiovascular disease. Cholesterol circulates in lipoproteins, particles that transport lipids through the aqueous environment of blood. Low-density lipoprotein, LDL, carries cholesterol to tissues and contributes to atherosclerotic plaque formation when present in excess. High-density lipoprotein, HDL, carries cholesterol back to the liver for excretion, a process that may reduce plaque burden. The goal of lipid-lowering therapy is typically to reduce LDL levels and sometimes to raise HDL or lower triglycerides. Statins inhibit HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis. By blocking endogenous cholesterol production, statins cause liver cells to upregulate LDL receptors, pulling more LDL from the blood to meet cellular cholesterol needs. The result is substantially reduced LDL levels and, in clinical trials, reduced risk of heart attack and stroke. Statins also have anti-inflammatory and plaque-stabilizing effects that may contribute to their benefit beyond lipid lowering. Side effects can include muscle symptoms, ranging from mild myalgia to rare but serious rhabdomyolysis where muscle breaks down, releasing contents into the bloodstream. Monitoring for muscle symptoms and, in some cases, liver function is part of statin therapy management. Other lipid-lowering agents work through different mechanisms. Fibrates activate peroxisome proliferator-activated receptors, increasing lipoprotein lipase activity and fatty acid oxidation, which lowers triglycerides and can raise HDL. Bile acid sequestrants bind bile acids in the intestine, preventing their reabsorption and forcing the liver to synthesize more from cholesterol, depleting hepatic cholesterol stores and upregulating LDL receptors. Ezetimibe inhibits cholesterol absorption in the intestine, reducing the amount of dietary and biliary cholesterol that enters the bloodstream. PCSK9 inhibitors are newer agents that prevent the degradation of LDL receptors, increasing the number available on liver cells and markedly lowering LDL levels. Combination therapy is common, using multiple agents with complementary mechanisms to achieve lipid targets that monotherapy cannot reach, or to reduce the doses of individual drugs and thereby minimize side effects. We transition now to drugs affecting the respiratory system, the apparatus that brings oxygen into the body and expels carbon dioxide. Respiration depends on open airways, functional alveoli where gas exchange occurs, and appropriate neural drive to breathe. Drugs affecting this system primarily target airway smooth muscle, inflammatory processes in the lungs, and respiratory secretions. Bronchodilators relax airway smooth muscle, increasing airflow and reducing the work of breathing. Beta-2 agonists, which we have mentioned, activate beta-2 receptors on bronchial smooth muscle, causing relaxation through a cascade involving cyclic AMP. Short-acting beta-2 agonists provide quick relief of bronchoconstriction in asthma or chronic obstructive pulmonary disease, while long-acting formulations provide sustained bronchodilation for maintenance therapy. The selectivity for beta-2 receptors reduces cardiac effects, though at higher doses or in susceptible individuals, some beta-1 stimulation can occur, causing tremor and tachycardia. Anticholinergics used in respiratory disease block muscarinic receptors in the airways, preventing cholinergic-mediated bronchoconstriction and reducing mucus secretion. These drugs are particularly useful in COPD, where cholinergic tone contributes significantly to airway narrowing. Inhaled formulations minimize systemic exposure and side effects, delivering drug directly to the airways while minimizing absorption into the bloodstream. Methylxanthines, such as theophylline, are older bronchodilators that work through multiple mechanisms, including phosphodiesterase inhibition, which increases cyclic AMP levels, and adenosine receptor antagonism. These drugs have a narrow therapeutic index, requiring blood level monitoring to ensure efficacy without toxicity. Their use has declined with the availability of safer alternatives, but they remain an option for patients not controlled with other therapies. Anti-inflammatory drugs are central to asthma management, addressing the underlying airway inflammation that drives the disease. Inhaled corticosteroids reduce inflammation by activating glucocorticoid receptors in airway cells, leading to decreased production of inflammatory mediators, reduced infiltration of inflammatory cells, and stabilization of airway responsiveness. Regular use prevents asthma exacerbations and reduces long-term airway remodeling. The inhaled route allows high local concentrations in the airways with minimal systemic exposure, reducing the risk of systemic corticosteroid side effects like bone loss, glucose intolerance, and immune suppression. Nevertheless, high doses or long-term use can still produce systemic effects, and local effects like oral thrush can occur if technique is poor or mouth rinsing after use is neglected. Leukotriene modifiers represent an alternative anti-inflammatory approach. Leukotrienes are inflammatory mediators produced by cells in the airways, contributing to bronchoconstriction, mucus secretion, and airway edema. Leukotriene synthesis inhibitors block their formation, while leukotriene receptor antagonists block their action at target cells. Both approaches reduce inflammation and can improve asthma control, particularly in patients with aspirin sensitivity or exercise-induced symptoms. Mast cell stabilizers prevent mast cell degranulation, blocking the release of histamine and other mediators that trigger bronchoconstriction and inflammation. These drugs are used prophylactically before anticipated exposures such as exercise or allergen contact, but they do not reverse acute bronchoconstriction. Mucolytics and expectorants modify respiratory secretions. Mucolytics break down the structure of mucus, making it less viscous and easier to clear. Expectorants theoretically increase respiratory tract fluid, thinning mucus, though evidence for their efficacy is limited. These agents are adjuncts in conditions where thick secretions impair airway clearance. Pharmacology of the central nervous system is vast and complex, reflecting the intricacy of the brain and spinal cord, the billions of neurons, the trillions of synapses, the multiple neurotransmitter systems that interact to produce consciousness, emotion, movement, and thought. Drugs affecting the CNS can be broadly categorized by their therapeutic use. Sedatives and hypnotics, anxiolytics, antidepressants, antipsychotics, mood stabilizers, anticonvulsants, analgesics, and drugs for neurodegenerative diseases. Each category targets specific neurotransmitter systems or neural pathways, attempting to restore balance in systems that have become dysregulated. Sedative hypnotics facilitate calmness and promote rest. Benzodiazepines enhance the effect of GABA, the primary inhibitory neurotransmitter in the CNS. GABA binds to GABA-A receptors, ligand-gated chloride channels that hyperpolarize neurons and reduce their excitability. Benzodiazepines bind to a modulatory site on these receptors, increasing the frequency with which the chloride channel opens in response to GABA, thereby amplifying inhibitory neurotransmission. The result is sedation, anxiolysis, muscle relaxation, and anticonvulsant effects. Different benzodiazepines have different durations of action based on their pharmacokinetics. Short-acting agents are used for inducing rest, while longer-acting ones provide sustained anxiolysis. Side effects include cognitive impairment, psychomotor slowing, and the potential for dependence with prolonged use, as the brain adapts to enhanced GABAergic tone and becomes reliant on the drug to maintain normal function. Non-benzodiazepine hypnotics, sometimes called Z-drugs, act at the same GABA-A receptors but bind more selectively to certain receptor subtypes, theoretically providing sedative effects with less muscle relaxation and fewer other side effects. In practice, their side effect profile is similar to benzodiazepines, including dependence potential. Barbiturates are older sedative hypnotics that also enhance GABAergic transmission, but do so more dangerously, capable of directly activating GABA-A receptors at high doses and suppressing respiration and cardiovascular function. Their use has largely been replaced by safer alternatives, though they retain roles in anesthesia and seizure control in specific situations. Antidepressants address mood disorders by modulating monoaminergic neurotransmission, the systems involving serotonin, norepinephrine, and dopamine. The monoamine hypothesis posits that depression results from deficient signaling in these systems, though the reality is certainly more complex. Selective serotonin reuptake inhibitors, or SSRIs, block the transporter that removes serotonin from the synapse, increasing the amount of serotonin available to bind to postsynaptic receptors. This increased signaling is thought to promote neuroplasticity, the formation of new synaptic connections, and ultimately to improve mood and emotional regulation, though the therapeutic effect takes weeks to develop, suggesting that direct neurotransmitter changes trigger slower adaptive processes that mediate clinical benefit. Serotonin norepinephrine reuptake inhibitors, or SNRIs, block reuptake of both serotonin and norepinephrine, providing dual enhancement of monoaminergic tone. Tricyclic antidepressants are older agents that also block monoamine reuptake, but do so less selectively, affecting multiple receptors, including histamine and muscarinic receptors, which contributes to a broader side effect profile: sedation, weight gain, dry mouth, constipation, and cardiovascular effects. Monoamine oxidase inhibitors block the enzyme that degrades monoamines, increasing their availability, but they interact dangerously with dietary tyramine and many medications, limiting their use to situations where other antidepressants have failed. Atypical antidepressants work through various mechanisms. Some modulate serotonin receptors directly, others affect norepinephrine and dopamine reuptake. Others have unique mechanisms involving melatonin receptors or multimodal serotonergic effects. The diversity of mechanisms reflects both the complexity of depression and the ongoing search for more effective or better tolerated treatments. Antipsychotics treat psychotic symptoms, hallucinations, delusions, and disorganized thinking, primarily by blocking dopamine receptors in the brain. The dopamine hypothesis of psychosis suggests that excessive dopaminergic signaling, particularly in mesolimbic pathways, underlies positive symptoms of schizophrenia. First-generation or typical antipsychotics are potent dopamine D2 receptor antagonists. While effective for positive symptoms, they produce motor side effects by blocking dopamine receptors in the basal ganglia, causing Parkinsonism, dystonia, akathisia, and with chronic use, tardive dyskinesia, a potentially irreversible movement disorder. Second-generation or atypical antipsychotics also block dopamine receptors, but tend to have higher affinity for serotonin 5-HT2A receptors, a profile thought to reduce motor side effects and potentially improve negative symptoms and cognitive function. However, atypical antipsychotics have their own side effect burden, including weight gain, metabolic disturbances, and sedation, reflecting their complex receptor pharmacology. Mood stabilizers treat bipolar disorder, a condition characterized by alternating episodes of mania and depression. Lithium, the oldest mood stabilizer, has multiple mechanisms that remain incompletely understood, including effects on intracellular signaling cascades and neurotransmitter release. Its narrow therapeutic index requires careful monitoring of blood levels to avoid toxicity, which can manifest as tremor, confusion, kidney dysfunction, and in severe cases, life-threatening complications. Certain anticonvulsants also stabilize mood, particularly valproate and lamotrigine, through mechanisms involving GABAergic enhancement, modulation of voltage-gated ion channels, or other effects on neuronal excitability. Anticonvulsants prevent or reduce seizures, which are episodes of excessive synchronized neuronal firing. Different anticonvulsants work through different mechanisms, reflecting the multiple ways that neuronal excitability can be modulated. Some enhance GABAergic inhibition, either by increasing GABA synthesis, blocking GABA degradation, or enhancing GABA receptor function. Others block voltage-gated sodium channels, stabilizing neuronal membranes and making it harder for action potentials to fire repetitively. Still others block voltage-gated calcium channels, particularly the T-type channels involved in thalamic oscillations that can generate absent seizures. Some have multiple mechanisms or mechanisms that remain unclear. The choice of anticonvulsant depends on seizure type, patient factors, and side effect profile, and many patients require trials of multiple agents or combinations to achieve seizure control. Analgesics relieve pain through various mechanisms. Non-opioid analgesics like acetaminophen and NSAIDs reduce pain through peripheral and central mechanisms, inhibiting prostaglandin synthesis and reducing inflammation and sensitization of pain pathways. Opioids are powerful analgesics that activate opioid receptors in the CNS, mimicking endogenous opioid peptides like endorphins and enkephalins. Mu-opioid receptor activation produces analgesia, euphoria, respiratory depression, constipation, and with repeated use, tolerance and dependence. Opioids are essential for managing severe pain, but their potential for misuse and addiction requires careful prescribing and monitoring. Different opioids vary in potency, duration of action, and receptor selectivity, allowing tailoring to clinical needs. Adjuvant analgesics are drugs not primarily designed for pain, but effective for certain pain types. Antidepressants, particularly SNRIs and tricyclics, relieve neuropathic pain by enhancing descending inhibitory pathways in the spinal cord. Anticonvulsants like gabapentin and pregabalin reduce neuropathic pain by modulating neuronal excitability and neurotransmitter release. These medications allow treatment of chronic pain conditions with reduced reliance on opioids. Drugs for neurodegenerative diseases attempt to slow disease progression or ameliorate symptoms. In Parkinson's disease, dopaminergic neurons in the substantia nigra degenerate, causing motor symptoms. Levodopa, a dopamine precursor that crosses the blood-brain barrier, is converted to dopamine in the brain, replenishing depleted neurotransmitter. It is combined with carbidopa, which blocks peripheral conversion to dopamine, reducing side effects and increasing the amount of levodopa that reaches the brain. Dopamine agonists directly stimulate dopamine receptors, providing symptom relief without requiring conversion. MAOB inhibitors block the breakdown of dopamine, extending its action. These approaches are symptomatic, not disease-modifying, and over time, disease progression and drug-related complications like dyskinesias and motor fluctuations present increasing challenges. In Alzheimer's disease, cholinesterase inhibitors modestly improve cognitive function by increasing acetylcholine availability in the brain, compensating for the loss of cholinergic neurons. NMDA receptor antagonists like memantine may provide neuroprotection by modulating glutamate signaling, though benefits are modest. Neither approach halts disease progression, and the search for disease-modifying therapies continues. We have journeyed now through autonomic pharmacology, cardiovascular drugs, respiratory medications, and CNS agents, exploring how different classes of drugs interact with specific physiological systems. Each system reveals the elegance of pharmacological intervention, the possibility of using chemistry to guide biology toward therapeutic ends. The principles remain consistent across systems: understanding endogenous signaling, designing molecules that modulate those signals, balancing desired effects against adverse effects, and recognizing that every drug is a conversation with the body, and the body always has a response. As we pause here, the systems we have discussed continue their work: hearts beating, lungs breathing, neurons firing, all coordinated by chemical signals that pharmacology has learned to influence with ever-increasing precision and care. We continue our exploration, moving deeper into the terrain of pharmacology, where the principles we have established begin to interconnect, revealing the integrated nature of drug therapy and physiological response. The body does not compartmentalize its functions as neatly as our categories suggest. Cardiovascular, respiratory, and neurological systems communicate constantly, adjusting to each other's activity, compensating for disturbances, maintaining the dynamic equilibrium we call health. Pharmacological interventions ripple through these interconnected systems, producing intended effects and unintended consequences, requiring us to think holistically about how drugs influence the unified whole of a living organism. Endocrine pharmacology addresses the hormonal systems that regulate metabolism, growth, reproduction, and stress responses. Hormones are chemical messengers released by endocrine glands into the bloodstream, traveling to distant target tissues where they bind to receptors and alter cellular function. Unlike neurotransmitters that signal across narrow synaptic gaps in milliseconds, hormones work over longer distances and timescales, coordinating physiological processes that unfold over minutes, hours, or days. Drugs affecting the endocrine system can supplement deficient hormones, block excessive hormone action, or modulate the synthesis and release of hormones themselves. Diabetes mellitus exemplifies endocrine dysfunction and the pharmacological approaches to managing it. In type 1 diabetes, autoimmune destruction of pancreatic beta cells eliminates insulin production, the hormone that enables glucose uptake by cells and storage as glycogen or fat. Without insulin, glucose accumulates in the bloodstream while cells starve for energy, a paradox of plenty that leads to metabolic derangement. Treatment requires insulin replacement, administered by injection or pump, since insulin is a peptide hormone that would be digested if taken orally. Different insulin formulations have different pharmacokinetic profiles. Rapid-acting insulins peak within an hour and clear quickly, useful for covering meals, while long-acting insulins provide steady baseline levels throughout the day. Matching insulin delivery to the body's needs requires attention to food intake, physical activity, and blood glucose monitoring, attempting to recreate the precise glucose control that a functioning pancreas provides automatically. Type 2 diabetes involves insulin resistance, where target tissues respond inadequately to insulin, and eventual beta cell dysfunction as the pancreas struggles to compensate. Multiple drug classes address different aspects of this pathophysiology. Metformin, a first-line agent, reduces hepatic glucose production and improves insulin sensitivity in peripheral tissues through mechanisms involving AMP-activated protein kinase, a cellular energy sensor. It does not stimulate insulin secretion, so it rarely causes hypoglycemia, and it may have cardiovascular and metabolic benefits beyond glucose control. Sulfonylureas stimulate insulin secretion by closing ATP-sensitive potassium channels in beta cells, depolarizing them and triggering insulin release. They effectively lower blood glucose, but carry risk of hypoglycemia and weight gain. The azolidinediones improve insulin sensitivity by activating peroxisome proliferator activated receptor gamma, altering gene expression in fat and muscle tissue, though concerns about fluid retention and cardiovascular effects limit their use. Incretin-based therapies harness gut hormones that enhance insulin secretion in response to meals. GLP-1 receptor agonists mimic glucagon-like peptide 1, stimulating insulin release, suppressing glucagon, slowing gastric emptying, and reducing appetite. these injectable medications produce glucose lowering with weight loss and possible cardiovascular benefits. DPP-4 inhibitors block the enzyme that degrades incretin hormones, prolonging their action and enhancing meal-related insulin secretion, though with more modest effects than GLP-1 agonists. SGLT2 inhibitors work through an entirely different mechanism, blocking glucose reabsorption in the kidney, causing excess glucose to be excreted in urine. This insulin-independent approach lowers glucose while producing modest weight loss and, unexpectedly discovered in clinical trials, significant reductions in heart failure and kidney disease progression. Thyroid pharmacology addresses disorders of thyroid hormone production. Hypothyroidism, insufficient thyroid hormone, causes fatigue, weight gain, cold intolerance, and slowed metabolism. Treatment is straightforward. Synthetic thyroid hormone replacement, typically levothyroxine, the T4 form that the body converts to the more active T3 as needed. Dosing aims to normalize thyroid-stimulating hormone levels, which rise when thyroid hormone is insufficient and fall when it is adequate, providing a sensitive marker for dose adjustment. Hyperthyroidism, excessive thyroid hormone, causes weight loss, heat intolerance, tremor, and tachycardia. Antithyroid drugs like methimazole block thyroid peroxidase, the enzyme that incorporates iodine into thyroid hormone precursors, reducing hormone synthesis. Beta blockers provide symptomatic relief by counteracting the cardiovascular effects of excess thyroid hormone, while definitive treatment with radioactive iodine or surgery is arranged. Corticosteroids are synthetic versions of cortisol, the stress hormone produced by the adrenal cortex. They have profound effects on metabolism, immune function, and inflammation, binding to glucocorticoid receptors throughout the body and altering the transcription of hundreds of genes. Therapeutically, corticosteroids are powerful anti-inflammatory and immunosuppressive agents used for conditions from asthma to autoimmune diseases to organ transplantation. Short-term use is relatively safe, but prolonged use suppresses the hypothalamic pituitary adrenal axis, the feedback system regulating cortisol production. The body downregulates its own cortisol synthesis in response to exogenous corticosteroids, and abrupt discontinuation can leave patients without adequate cortisol to handle stress, a potentially life-threatening situation. Tapering doses gradually allows the HPA axis to recover. Chronic corticosteroid use also causes numerous adverse effects: bone loss, muscle wasting, glucose intolerance, increased infection risk, mood changes, and altered fat distribution. These risks necessitate using the lowest effective dose for the shortest time possible. Reproductive hormones regulate fertility, sexual development, and secondary sexual characteristics. Oral contraceptives combine synthetic estrogens and progestins to suppress ovulation by providing negative feedback to the hypothalamus and pituitary, preventing the surge of luteinizing hormone that triggers egg release. They also thicken cervical mucus and thin the endometrial lining, creating additional barriers to conception. Different formulations vary in hormone doses and ratios, allowing individualization based on side effects and contraindications. Progestin-only contraceptives avoid estrogen-related risks, particularly important for women with cardiovascular risk factors or migraine with aura, where estrogen may increase stroke risk. Hormone replacement therapy addresses menopausal symptoms, supplementing estrogen and often progestin to relieve hot flashes, vaginal dryness, and other manifestations of declining ovarian function. Benefits and risks require careful consideration. as hormone therapy can improve quality of life but may increase risks of cardiovascular events, blood clots, and certain cancers, with effects varying by formulation, dose, timing, and individual patient factors. Antimicrobial pharmacology represents a unique domain where drugs target not human cells but invading organisms, bacteria, viruses, fungi, and parasites. The goal is selective toxicity, harming the pathogen while sparing the host, exploiting differences between microbial and human biology. Bacteria have cell walls, different ribosomal structures, and unique metabolic pathways that humans lack, providing targets for antibacterial drugs. Viruses hijack host cellular machinery, making selective toxicity more challenging, but still achievable by targeting viral-specific enzymes or processes. Antibacterial agents, commonly called antibiotics, are classified by their mechanism of action and spectrum of activity. Beta-lactam antibiotics, including penicillins, cephalosporins, and carbapenems, inhibit bacterial cell wall synthesis by binding to penicillin-binding proteins, enzymes that cross-link peptidoglycan strands in the cell wall. Without a functional cell wall, bacteria cannot maintain their shape against osmotic pressure and lyse. Beta-lactams are bactericidal, killing bacteria rather than merely inhibiting their growth. Different beta-lactams have different spectra based on their ability to penetrate the outer membrane of gram-negative bacteria and their resistance to bacterial enzymes called beta-lactamases that hydrolyze the beta-lactam ring, inactivating the antibiotic. Bacterial resistance to beta-lactams occurs through several mechanisms: production of beta-lactamases, alteration of penicillin-binding proteins so they no longer bind the drug, and changes in outer membrane porins that prevent drug entry. Combination products pair beta-lactams with beta-lactamase inhibitors, molecules that inactivate the bacterial enzymes, restoring the antibiotic's efficacy. The evolutionary arms race between antibiotic development and bacterial resistance is ongoing, with resistance mechanisms spreading through bacterial populations via horizontal gene transfer, creating strains resistant to multiple drug classes. Glycopeptides like vancomycin also inhibit cell wall synthesis, but through a different mechanism, binding to peptidoglycan precursors and preventing their incorporation into the growing wall. These large molecules cannot penetrate gram-negative outer membranes, limiting their spectrum to gram-positive bacteria. Vancomycin is often reserved for resistant organisms, particularly methicillin-resistant Staphylococcus aureus, though vancomycin resistance has now emerged, driven by genes that alter the peptidoglycan structure, so vancomycin can no longer bind effectively. Protein synthesis inhibitors exploit differences between bacterial and human ribosomes. Aminoglycosides bind to the 30S ribosomal subunit, causing misreading of mRNA and producing defective proteins. They are bactericidal and particularly effective against gram-negative organisms, but carry risks of kidney damage and hearing loss, requiring monitoring of drug levels and renal function. Tetracyclines also bind the 30S subunit, preventing aminoacyl tRNA from binding and halting protein synthesis. They are bacteriostatic, preventing bacterial growth rather than killing, relying on host immunity to clear the infection. Tetracyclines have broad-spectrum activity and unique applications, like treating intracellular pathogens and certain tick-borne diseases. Macrolides bind to the 50S ribosomal subunit, blocking the translocation step of protein synthesis. They are bacteriostatic, with good activity against respiratory pathogens and excellent tissue penetration. Fluoroquinolones inhibit bacterial topoisomerases, enzymes that manage DNA supercoiling during replication and transcription. By preventing proper DNA topology management, fluoroquinolones cause DNA breaks and bacterial death. They are bactericidal with broad-spectrum activity and good oral bioavailability, making them valuable for many infections, though concerns about side effects including tendon rupture and neuropsychiatric effects have led to restricted use. Sulfonamides and trimethoprim inhibit bacterial folate synthesis, a pathway humans lack since we obtain folate from diet. Bacteria must synthesize folate de novo, and blocking this pathway prevents nucleotide synthesis and cell division. The combination of sulfamethoxazole and trimethoprim, which inhibit sequential steps in folate synthesis, is synergistic and widely used for urinary and other infections. Antiviral drugs face the challenge that viruses use host cellular machinery for replication, limiting targets for selective toxicity. Most antivirals target viral-specific enzymes or processes. Nucleoside and nucleotide analogues mimic natural building blocks of DNA or RNA, but cause chain termination or mutations when incorporated by viral polymerases. Acyclovir, used for herpes viruses, is activated preferentially in infected cells by viral thymidine kinase, achieving selectivity. Reverse transcriptase inhibitors treat HIV, targeting the viral enzyme that converts RNA to DNA, a step unique to retroviruses. Protease inhibitors prevent the cleavage of viral polyproteins into functional units, blocking virion maturation. Neuraminidase inhibitors, used for influenza, prevent viral release from infected cells, limiting spread. Combination antiviral therapy is standard for HIV, using multiple drugs with different mechanisms to suppress viral replication and prevent resistance emergence. Antifungal drugs target ergosterol, a steroid component of fungal cell membranes absent in human cells. Polyenes like amphotericin B bind directly to ergosterol, creating pores in the membrane and causing cell death. Amphotericin is highly effective but toxic, particularly to kidneys, reserved for serious systemic fungal infections. Azoles inhibit ergosterol synthesis, reducing membrane integrity and fungal growth. Different azoles have different spectra and pharmacokinetics, with newer triazoles offering broad spectrum activity and better tolerability. Echinocandins inhibit glucan synthesis, a component of the fungal cell wall, providing another mechanism for selectivity since human cells lack cell walls. Antiparasitic drugs address a diverse array of organisms from single-celled protozoa to multicellular helminths. Each parasite has unique biology requiring specific therapeutic approaches. Antimalarial drugs target different stages of the Plasmodium life cycle, some acting on blood stages to treat acute infection, others on liver stages to prevent relapse or provide prophylaxis. Drug resistance is a major challenge, particularly with Plasmodium falciparum, leading to combination therapies with artemisinin, derivatives, and partner drugs. Antihelminthic drugs paralyze or kill worms through various mechanisms, often targeting neuromuscular function unique to the parasites. Antimicrobial stewardship is the principle of using antibiotics judiciously to preserve their effectiveness. Overuse and misuse of antibiotics drives resistance, reducing therapeutic options for future infections. Appropriate prescribing means confirming bacterial infection before starting antibiotics, choosing narrow-spectrum agents when possible, using adequate doses for appropriate durations, and avoiding antibiotics for viral infections where they provide no benefit. The tragedy of the commons applies to antibiotics. Individual benefit from easy access conflicts with collective benefit from preserving efficacy through restrained use. Chemotherapy for cancer represents another form of selective toxicity, though here the target is human cells that have become malignant. Cancer cells differ from normal cells in their uncontrolled division, resistance to growth inhibition, ability to invade tissues and metastasize, and altered metabolism. Chemotherapy exploits these differences, particularly the rapid division rate. Drugs that interfere with DNA replication, cell division, or metabolic processes required for growth preferentially affect rapidly dividing cells, including cancer cells, but also normal cells that divide frequently like bone marrow, gastrointestinal epithelium, and hair follicles. This explains the characteristic side effects of chemotherapy: myelosuppression causing anemia and infection risk, mucositis, nausea, and hair loss. Alkylating agents cross-link DNA strands, preventing replication and transcription, causing apoptosis in dividing cells. Anti-metabolites mimic nucleotides or folate, disrupting DNA and RNA synthesis. Topoisomerase inhibitors prevent proper DNA topology management during replication. Microtubule inhibitors prevent spindle formation, blocking mitosis. Each class affects specific phases of the cell cycle or specific molecular targets. And combination chemotherapy uses multiple agents with different mechanisms to maximize cancer cell kill while managing toxicity. Targeted therapies represent a shift toward exploiting specific molecular abnormalities in cancer cells. Tyrosine kinase inhibitors block signaling pathways that drive cancer cell proliferation and survival, often targeting specific mutations present in the tumor but not in normal cells. Monoclonal antibodies bind to cancer cell surface proteins, marking them for immune destruction or blocking growth signals. Immune checkpoint inhibitors unleash the immune system by blocking receptors that normally prevent T cells from attacking the body's own tissues, allowing recognition and destruction of cancer cells. These targeted approaches can be more effective and less toxic than traditional chemotherapy. Though resistance develops as cancer cells evolve, immunopharmacology encompasses drugs that modulate immune function. Immunosuppressants prevent organ rejection after transplantation and treat autoimmune diseases where the immune system attacks the body's own tissues. Corticosteroids, which we discussed earlier, are potent immunosuppressants. Calcineurin inhibitors like cyclosporine and tacrolimus block T-cell activation by inhibiting a phosphatase required for transcription of cytokine genes. mTOR inhibitors prevent T-cell proliferation by blocking a kinase involved in cell growth and division. Antiproliferative agents like azathioprine and mycophenolate inhibit DNA synthesis in dividing lymphocytes. Biological agents, including monoclonal antibodies, deplete specific immune cell populations or block cytokines that drive inflammation. Immunosuppression carries the obvious risk of increased infection susceptibility and possible increased cancer risk with prolonged use, requiring careful balancing of sufficient suppression to prevent rejection or control autoimmunity against preservation of enough immune function to fight infections and malignancies. Conversely, immunostimulants enhance immune function. Vaccines are the most successful example, presenting antigens to the immune system to generate protective memory without causing disease. Adjuvants in vaccines enhance the immune response, creating stronger and longer-lasting immunity. Cytokines like interferons and interleukins are used therapeutically to boost antiviral or anti-tumor immunity, though their systemic effects can cause significant flu-like symptoms and other toxicities. Gastrointestinal pharmacology addresses the digestive system's diverse functions: secretion of acid and enzymes, motility that propels contents through the tract, absorption of nutrients, and the gut's role in immune function and hormone production. Drugs affecting the GI system can reduce acid production, neutralize existing acid, alter motility, replace digestive enzymes, or modify the gut microbiome. Proton pump inhibitors block the H+K+ ATPase in gastric parietal cells, the pump that secretes hydrogen ions into the stomach lumen, creating acid. By irreversibly inhibiting this pump, PPIs profoundly reduce acid production, providing relief from peptic ulcers, gastroesophageal reflux, and allowing healing of erosive esophagitis. The effect lasts until new pumps are synthesized, giving these drugs a long duration of action despite relatively short half-lives. Concerns about long-term PPI use include possible increased fracture risk, Clostridium difficile infection, and nutrient malabsorption, though benefits typically outweigh risks for appropriate indications. H2 receptor antagonists block histamine stimulation of acid secretion, an alternative mechanism for reducing gastric acid production. They are less potent than PPIs, but sufficient for milder disease and have a role in acute symptom relief. Antacids neutralize existing acid through chemical reactions, providing rapid but temporary relief. They contain various combinations of aluminum, magnesium, and calcium salts, each with different side effect profiles related to the metal ion. Aluminum causes constipation, magnesium causes diarrhea. Combinations attempt to balance these effects. Antiemetics prevent or treat nausea and vomiting, which can result from diverse causes: motion, medications, chemotherapy, gastrointestinal disease, neurological conditions, and pregnancy. Different mechanisms drive nausea in different situations, and antiemetics target various pathways. Serotonin 5-HT3 receptor antagonists block receptors in the chemoreceptor trigger zone and gastrointestinal tract, particularly effective for chemotherapy-induced nausea. Dopamine antagonists block D2 receptors in the chemoreceptor trigger zone, useful for various causes of nausea, but carrying risk of extrapyramidal side effects. Antihistamines and anticholinergics are effective for motion sickness by blocking vestibular inputs to the vomiting center. NK1 receptor antagonists block substance P, adding efficacy to serotonin antagonists for chemotherapy-induced nausea. Laxatives treat constipation through multiple mechanisms. Bulk-forming laxatives are indigestible fibers that absorb water, increasing stool mass and stimulating peristalsis. Osmotic laxatives draw water into the intestinal lumen, softening stool and increasing volume. Stimulant laxatives irritate the intestinal mucosa or stimulate enteric nerves, increasing motility. Stool softeners increase water penetration into stool. Each type has specific indications and potential side effects, with chronic stimulant laxative use potentially causing dependency. Antidiarrheals reduce stool frequency and fluidity. Loperamide activates opioid receptors in the enteric nervous system, slowing motility and increasing fluid absorption, without significant CNS effects since it does not cross the blood-brain barrier well. Bismuth subsalicylate has antimicrobial and anti-inflammatory properties, useful for infectious diarrhea and traveler's diarrhea. Treatment of diarrhea requires identifying the cause as infectious diarrhea sometimes benefits from allowing pathogen elimination, and anti-motility agents can worsen certain infections. Inflammatory bowel disease drugs address chronic intestinal inflammation. Aminosalicylates like mesalamine deliver anti-inflammatory compounds directly to the intestinal mucosa. Corticosteroids provide potent anti-inflammatory effects for acute flares. Immunosuppressants and biological agents targeting specific inflammatory cytokines like TNF-alpha are used for maintenance therapy in moderate to severe disease, attempting to induce and maintain remission while minimizing corticosteroid use. Pharmacology intersects with nutrition through drugs that supplement deficiencies, treat metabolic disorders, or provide nutritional support when oral intake is inadequate. Vitamin and mineral supplements correct deficiencies that result from inadequate dietary intake, malabsorption, or increased metabolic demands. Iron supplements treat iron deficiency anemia, though absorption is limited and GI side effects common. Vitamin D supplementation addresses widespread deficiency, particularly important for bone health. Vitamin B12 injections bypass absorption defects in pernicious anemia or malabsorption syndromes. Folate supplementation prevents neural tube defects when taken before conception and during early pregnancy. Drugs affecting bone metabolism address osteoporosis and other metabolic bone diseases. Bisphosphonates inhibit osteoclasts, the cells that resorb bone, shifting the balance toward bone formation and increasing bone density. They require specific dosing instructions, taken on an empty stomach with water, remaining upright for at least 30 minutes to prevent esophageal irritation. Selective estrogen receptor modulators provide estrogen-like effects on bone while blocking estrogen effects on breast and uterus, reducing fracture risk without increasing cancer risk. Parathyroid hormone analogs stimulate bone formation when given intermittently, though continuous elevation causes bone resorption. An example of how dosing schedule can fundamentally change a drug's effect. Denosumab, a monoclonal antibody against RANKL, inhibits osteoclast formation and activity, reducing bone resorption with a different mechanism than bisphosphonates. Throughout our journey, we have seen how drugs interact with specific molecular targets to produce effects that cascade through interconnected physiological systems. Each drug class represents a conversation between chemistry and biology, between human design and evolutionary adaptation, between therapeutic intention and complex biological response. The body is not a collection of independent systems, but an integrated whole, and pharmacology must account for these connections, anticipating how intervention in one system will ripple through others, producing the symphony of effects we call pharmacotherapy. We have explored autonomic, cardiovascular, respiratory, central nervous system, endocrine, antimicrobial, oncologic, immunologic, gastrointestinal, and nutritional pharmacology, moving through these domains with attention to mechanisms, principles, and the elegant complexity of how molecules influence life. As we transition toward the synthesis and completion of this exploration, we carry an appreciation for the depth and breadth of pharmacology, the science that allows chemistry to serve healing, always within the context of the living systems that both receive and respond to these molecular messages. As we move into the final portion of our journey through pharmacology, we gather the threads we have woven, drawing connections between the diverse systems and drug classes we have explored, recognizing patterns that emerge across therapeutic categories, and appreciating the unified principles that guide rational drug therapy. Pharmacology is not merely a catalog of medications and their effects. but a coherent framework for understanding how chemical intervention can guide biological systems toward health. The wisdom lies not in memorizing individual drugs, but in comprehending the logic that underlies their use, the mechanisms that predict their effects, and the principles that govern their safe and effective application. We turn now to special populations and the modifications required when standard pharmacological approaches encounter unique physiological circumstances. Pediatric pharmacology recognizes that children are not simply small adults. Their physiology differs in ways that profoundly affect drug disposition and response. Neonates and infants have immature organ systems, particularly liver and kidneys, reducing their capacity to metabolize and excrete drugs. Enzyme systems develop at different rates. Some are deficient at birth and mature over weeks to months. Others are present but have different activity patterns than in adults. Renal function, measured by glomerular filtration rate adjusted for body surface area, is reduced in neonates and gradually increases to adult levels by the first year of life. These developmental changes mean that drugs accumulate more readily in young children, requiring dose adjustments often based on weight or body surface area rather than age alone. Body composition changes with age. Neonates have higher total body water and lower fat content than adults, affecting the volume of distribution for hydrophilic and lipophilic drugs differently. Protein binding may be reduced due to lower albumin levels and different binding affinity, increasing the free fraction of highly protein-bound drugs and potentially enhancing both efficacy and toxicity. The blood-brain barrier is more permeable in early life, allowing drugs greater access to the central nervous system, which can be beneficial for treating CNS infections but increases risk of neurotoxic effects. Pharmacodynamic differences also exist. Receptors may have different density, distribution, or signaling efficiency in developing tissues. Responses to drugs can be qualitatively different in children, sometimes more sensitive, sometimes less, depending on the specific drug and system. The therapeutic index may be narrower, with less margin for error between effective and toxic doses. All of these factors necessitate careful dose calculation, often requiring specialized references and formulations designed for pediatric use. With liquid suspensions, chewable tablets, and precise dosing devices replacing the adult forms that would be impractical or impossible to accurately dose in small children. Geriatric pharmacology addresses the opposite end of the age spectrum, where accumulated physiological changes, multiple chronic diseases, and polypharmacy create unique challenges. Aging affects every aspect of pharmacokinetics. Gastric pH rises, gastric emptying slows, and intestinal blood flow decreases, potentially altering drug absorption, though the clinical significance is usually modest. Body composition shifts, with decreased lean body mass and total body water but increased fat mass, changing volumes of distribution. Hydrophilic drugs have smaller volumes of distribution and potentially higher plasma concentrations, while lipophilic drugs have larger volumes of distribution and prolonged half-lives as they accumulate in expanded fat stores. Hepatic blood flow decreases with age, and while total liver size and hepatocyte number decline, functional hepatic enzyme capacity is generally preserved, though with reduced reserve. First-pass metabolism may be reduced due to decreased hepatic blood flow, potentially increasing bioavailability of drugs normally extensively metabolized before reaching systemic circulation. Phase 1 metabolism. The oxidative reactions mediated by cytochrome P450 enzymes. declines more than phase 2 conjugation reactions, though considerable variability exists between individuals. Renal function declines progressively with age, with glomerular filtration rate decreasing approximately 1% per year after age 40 in many individuals, though some maintain function into old age. This decline profoundly affects drugs eliminated renally, requiring dose reduction or interval extension to prevent accumulation and toxicity. Creatinine clearance, estimated from serum creatinine, age, weight, and sex, guides dosing adjustments, though serum creatinine may underestimate the degree of renal impairment in elderly patients with reduced muscle mass. Pharmacodynamic changes include altered receptor sensitivity, changes in homeostatic mechanisms, and reduced physiological reserve. Elderly patients may be more sensitive to central nervous system depressants, experiencing confusion, falls, or oversedation at doses well tolerated by younger adults. Orthostatic hypotension is more common as baroreceptor reflexes become less responsive. Anticholinergic effects are particularly problematic, contributing to confusion, urinary retention, and constipation. The concept of potentially inappropriate medications in older adults recognizes that certain drugs carry risks that outweigh benefits in this population, either because of pharmacokinetic or pharmacodynamic changes, or because safer alternatives exist. Polypharmacy, the concurrent use of multiple medications, is common in elderly patients with multiple chronic conditions. Each additional drug increases the risk of drug-drug interactions, adverse effects, and medication errors. The medication burden can become overwhelming, affecting adherence and quality of life. Deprescribing, the systematic process of tapering or stopping medications that may no longer be beneficial or whose risks exceed benefits, is increasingly recognized as important in geriatric care. The goal is to optimize rather than maximize the medication regimen, ensuring that each drug provides meaningful benefit with acceptable risk. Pregnancy introduces considerations for two individuals, the mother and developing fetus, whose needs may differ or conflict. Pregnancy causes profound physiological changes affecting pharmacokinetics. Blood volume expands by up to 50%, potentially decreasing drug concentrations. Cardiac output increases, enhancing renal blood flow and glomerular filtration rate, increasing the clearance of renally eliminated drugs and sometimes requiring dose increases to maintain therapeutic levels. Hepatic enzyme activity changes in complex ways, with some pathways induced and others inhibited, affecting drug metabolism unpredictably. Gastric emptying slows and intestinal transit time increases, potentially affecting absorption. Plasma protein concentrations fall due to hemodilution, increasing the free fraction of protein-bound drugs. Most drugs cross the placenta to some degree, exposing the fetus to maternal medications. The extent of transfer depends on molecular size, lipophilicity, protein binding, and placental metabolism. Teratogenic drugs can cause structural malformations, particularly during the first trimester when organogenesis occurs. Some drugs are absolutely contraindicated in pregnancy due to known teratogenic effects. Isotretinoin causes severe craniofacial and cardiac defects. ACE inhibitors and ARBs cause renal dysfunction and growth restriction. Valproate causes neural tube defects. Other drugs have uncertain risk, with inadequate human data to definitively establish safety or danger. Pregnancy categories historically guided drug selection, though these have been replaced by more nuanced narrative descriptions of available evidence and known risks. The principle of risk-benefit assessment becomes paramount in pregnancy. Some conditions require treatment despite potential fetal risk because untreated maternal disease poses greater danger to both mother and fetus. Hypertension, diabetes, epilepsy, psychiatric disorders, and infections all may require pharmacological management during pregnancy. Choosing medications with the best safety profiles while maintaining disease control. The risk of untreated maternal disease must be weighed against potential drug risks, often a difficult calculus made more challenging by limited data. Lactation introduces another route of drug transfer, as many medications enter breast milk to varying degrees. Drug passage into milk depends on similar factors as placental transfer, with lipophilic, non-ionized, low molecular weight drugs achieving higher milk concentrations. The amount an infant receives depends on drug concentration in milk, volume of milk consumed, and the infant's ability to absorb and eliminate the drug. Most drugs appear in milk at low levels, and breastfeeding can often continue with appropriate medication selection. But some drugs achieve sufficient infant exposure to cause concern, requiring either medication change or temporary interruption of breastfeeding. The benefits of breastfeeding must be considered alongside medication necessity and risk, another complex balance. Renal disease affects drug pharmacokinetics profoundly since the kidneys are the primary route of elimination for many drugs and their metabolites. As glomerular filtration rate declines, drugs that depend on renal excretion accumulate unless doses are reduced. Dose adjustment can involve reducing individual doses, extending dosing intervals, or both, depending on whether maintaining peak concentrations or steady concentrations is more important for efficacy and safety. Loading doses generally do not require adjustment since they depend on volume of distribution rather than clearance, but maintenance doses must be reduced proportional to the reduction in clearance. Chronic kidney disease also affects drug distribution through altered protein binding, as uremia decreases the binding of acidic drugs to albumin, increasing their free fraction. Renal disease can alter drug metabolism, with accumulation of uremic toxins inhibiting hepatic enzymes. Dialysis removes some drugs, but not others, depending on molecular size, protein binding, and volume of distribution. Highly protein-bound drugs, or those with large volumes of distribution, are minimally removed by dialysis, while small, water-soluble, minimally protein-bound drugs can be significantly removed, sometimes requiring supplemental doses after dialysis sessions. Hepatic disease affects drug metabolism and synthesis of proteins required for drug distribution and coagulation. In cirrhosis, decreased hepatic blood flow reduces first-pass metabolism, increasing bioavailability of orally administered drugs normally extensively metabolized. Hepatocyte dysfunction reduces metabolic capacity for both phase I and phase II reactions. Decreased albumin synthesis reduces protein binding, increasing free drug fractions. Portal hypertension creates portosystemic shunts that allow blood to bypass the liver, further reducing first-pass metabolism and drug clearance. These changes require dose reductions for many drugs, though predicting the magnitude is difficult because liver function tests correlate imperfectly with metabolic capacity. The Child-Pugh score, which assesses cirrhosis severity based on bilirubin, albumin, prothrombin time, ascites, and encephalopathy, provides rough guidance for dose adjustment, though specific recommendations vary by drug. Genetic polymorphisms, variations in genes encoding drug metabolizing enzymes, transporters, and receptors cause inter-individual variability in drug response. Pharmacodynamics studies how genetic variation influences pharmacokinetics and pharmacodynamics, with the goal of personalizing medication selection and dosing based on individual genotype. Cytochrome P450 enzymes show particularly well-characterized polymorphisms. CYP2D6 metabolizes many psychiatric medications, beta blockers, opioids, and other drugs. Individuals can be poor metabolizers, with little or no functional enzyme due to inactive alleles. Intermediate metabolizers with reduced activity, normal or extensive metabolizers with typical activity, or ultra-rapid metabolizers with gene duplications producing excessive enzyme. Poor metabolizers accumulate drugs metabolized by CYP2D6, experiencing toxicity at standard doses, while ultra-rapid metabolizers clear these drugs quickly, achieving subtherapeutic levels, or, in the case of prodrugs activated by CYP2D6, experiencing toxicity from rapid prodrug conversion. CYP2C19 metabolizes proton pump inhibitors, antiplatelet drugs, and antidepressants, with similar metabolizer phenotypes affecting response. CYP2C9 metabolizes warfarin, and polymorphisms influence warfarin dose requirements and bleeding risk. Thiopurine methyltransferase metabolizes azathioprine and mercaptopurine, and deficiency causes severe myelosuppression at standard doses. Genetic testing can identify these polymorphisms before starting therapy, allowing prospective dose adjustment or drug selection to avoid adverse effects or therapeutic failure. Pharmacodynamics extends beyond metabolism to drug targets. Genetic variants in receptors can affect drug binding affinity or signaling efficiency, influencing response. Variants in disease-related genes can predict which patients will benefit from targeted therapies. In oncology, tumor genotyping identifies mutations that predict response to specific targeted agents, guiding treatment selection. The vision of precision medicine, tailoring therapy to individual genetic profiles, is gradually becoming reality, though challenges of cost, access to testing, and integration of genetic data into clinical workflows remain. Drug development is the process by which new medications move from concept to clinical use, a lengthy and expensive endeavor spanning years and costing billions. It begins with drug discovery, identifying compounds with desired biological activity through screening of chemical libraries, rational design based on target structure, or modification of natural products. Lead compounds undergo optimization, modifying their structure to improve potency, selectivity, pharmacokinetic properties, and manufacturability while reducing toxicity. Preclinical development involves extensive in vitro and animal studies assessing pharmacology, pharmacokinetics, and toxicology. Regulatory agencies require data on absorption, distribution, metabolism, and excretion, acute and chronic toxicity, carcinogenic potential, and reproductive toxicity before human trials can begin. These studies identify doses to use in early human trials and safety signals to monitor. Clinical development proceeds through phases. Phase 1 trials enroll small numbers of healthy volunteers, or patients for cancer drugs too toxic for healthy subjects, primarily assessing safety, tolerability, and pharmacokinetics in humans. Doses are escalated cautiously to identify the maximum tolerated dose and establish pharmacokinetic parameters. Phase 2 trials enroll patients with the target disease, evaluating efficacy at various doses while continuing to assess safety. These studies determine the dose and regimen to carry forward. Phase 3 trials are large randomized controlled trials comparing the new drug to placebo or standard therapy. providing definitive evidence of efficacy and safety required for regulatory approval. These trials enroll hundreds or thousands of patients, cost enormous sums, and take years to complete. Regulatory review by agencies like the FDA involves submission of a new drug application containing all preclinical and clinical data. Reviewers assess whether the evidence demonstrates that benefits outweigh risks for the proposed indication. Approval allows marketing, but surveillance continues through phase or full post-marketing studies and adverse event reporting systems that detect rare adverse effects not apparent in clinical trials. The drug development process has limitations. Clinical trials enroll selected populations, excluding pregnant women, children, elderly patients with multiple comorbidities, and others who represent much of real-world practice. Trials are relatively short, missing delayed or cumulative toxicities. Sample sizes detect common adverse effects, but miss rare ones. The artificial conditions of trials differ from actual clinical use. These limitations mean that post-marketing experience continues to inform understanding of drugs' benefits and risks, sometimes leading to new indications, warnings, or withdrawals. Adverse drug reactions are harmful, unintended responses occurring at doses used for therapy. They represent a major cause of morbidity and mortality, emergency department visits, and hospitalizations. Type A reactions are dose-dependent and predictable from the drug's pharmacology, extensions of the known mechanism that become excessive. Examples include bleeding from anticoagulants, hypoglycemia from insulin, or bradycardia from beta blockers. These reactions are common, related to dose, and usually avoidable with careful dosing and monitoring. Type B reactions are idiosyncratic, unpredictable, and unrelated to dose or mechanism. Examples include anaphylaxis to penicillin or toxic epidermal necrolysis from certain antibiotics. These reactions are rare, potentially severe, and not preventable through dose adjustment, though they can sometimes be avoided by screening for risk factors or genetic susceptibilities. Drug interactions occur when one drug alters the effect of another. Pharmacokinetic interactions involve changes in absorption, distribution, metabolism, or excretion. Examples include drugs that induce or inhibit metabolic enzymes, drugs that compete for protein binding sites, or drugs that alter gastric pH or motility affecting absorption. Pharmacodynamic interactions involve drugs acting on the same or related systems, producing additive, synergistic, or antagonistic effects. Examples include combining two CNS depressants causing excessive sedation, or combining an anticoagulant with an antiplatelet drug increasing bleeding risk. Medication errors are preventable events that may cause or lead to inappropriate medication use or patient harm. They occur at multiple points: prescribing errors from incorrect drug selection, dose or route, dispensing errors from pharmacy mistakes, administration errors from incorrect dose, timing, or patient, and monitoring errors from failure to detect adverse effects or adjust therapy appropriately. System-based approaches to error prevention include computerized order entry with clinical decision support, barcode medication administration, pharmacist review of orders, and standardized protocols. A culture of safety that encourages reporting and learning from errors rather than blaming individuals is essential for improvement. Adherence, the extent to which patients take medications as prescribed, profoundly affects therapeutic outcomes. Non-adherence is common, estimated at 30 to 50% for chronic medications, and results from multiple factors: complexity of regimen, side effects, cost, lack of understanding about the medication's purpose, forgetfulness, or beliefs about medication necessity and safety. Strategies to improve adherence include simplifying regimens, using combination products or once-daily formulations, providing clear instructions and education, addressing barriers like cost through generic substitution or assistance programs, and using adherence aids like pill organizers or reminders. The placebo effect, improvement from an inert treatment, demonstrates the powerful influence of expectation, context, and the therapeutic relationship on patient outcomes. Placebos can produce measurable physiological changes through neurobiological pathways involving endogenous opioids, dopamine, and other systems. Recognizing the placebo effect is important for interpreting clinical trials, which use placebo controls to isolate the specific pharmacological effect from the contextual effects present in any therapeutic encounter. It also reminds us that the context of medication administration, the explanation given, the relationship with the prescriber, and the patient's beliefs all influence outcomes beyond the drug's molecular mechanism. The nocebo effect, the opposite phenomenon, where negative expectations produce adverse outcomes, can contribute to side effect experiences. Some adverse effects attributed to medications may result partly from expectation rather than pharmacology, which is why informed consent must balance providing necessary information against creating anxiety that manifests as symptoms. Over-the-counter medications are available without prescription, deemed safe enough for self-administration when label directions are followed. They treat minor, self-limiting conditions and include analgesics, cough and cold remedies, antacids, antihistamines, and many others. While generally safe, OTC medications are not without risk, particularly when taken in excessive doses, combined with prescription medications causing interactions, or used by individuals with contraindications. Acetaminophen overdose is a leading cause of acute liver failure, often from unintentional excessive use when multiple products containing acetaminophen are taken simultaneously. NSAIDs carry cardiovascular and gastrointestinal risks even when purchased without prescription. Patient education about proper use of OTC medications and screening for their use when prescribing new medications are important aspects of comprehensive medication management. Herbal supplements and dietary products are widely used, often without healthcare provider knowledge. Some have pharmacological activity and can interact with prescription medications, either through pharmacokinetic interactions affecting drug metabolism or pharmacodynamic interactions affecting the same physiological systems. St. John's wort induces CYP3A4 and can reduce levels of numerous drugs, including oral contraceptives, immunosuppressants, and antiretrovirals, potentially causing therapeutic failure. Ginkgo and garlic have antiplatelet effects that can enhance bleeding when combined with anticoagulants. Quality control of supplements is inconsistent, with variation in active ingredient content between products and batches. Asking patients about supplement use and educating them about potential interactions is increasingly important. Antibiotic stewardship programs aim to optimize antibiotic use in healthcare institutions, promoting appropriate selection, dosing, route, and duration while minimizing unnecessary use. The goals are to improve patient outcomes, reduce adverse effects including Clostridioides difficile infection, and slow the development and spread of antimicrobial resistance. Strategies include requiring approval for certain broad-spectrum or restricted antibiotics, automatic de-escalation from broad to narrow-spectrum agents based on culture results, and default durations for common infections to prevent unnecessarily prolonged courses. Education of prescribers about resistance patterns and appropriate antibiotic choices is central to these programs. Pain management involves a multimodal approach combining pharmacological and non-pharmacological strategies. The WHO analgesic ladder provides a framework, starting with non-opioid analgesics for mild pain, adding weak opioids for moderate pain, and using strong opioids for severe pain, with adjuvant medications at any step for specific pain types. Acute pain management aims for rapid relief with the expectation of resolution as healing occurs. Chronic pain management is more complex, balancing analgesia against side effects and dependence risks, often employing non-opioid strategies including physical therapy, psychological approaches, interventional procedures, and medications like antidepressants or anticonvulsants that modulate pain pathways. The opioid epidemic has transformed pain management, highlighting the risks of prescription opioids, including dependence, addiction, overdose, and death. Prescribing practices have been scrutinized and modified, with emphasis on minimizing opioid exposure through several strategies, using non-opioid and non-pharmacological approaches first, prescribing the lowest effective dose for the shortest necessary duration, screening for risk factors for opioid use disorder, monitoring through prescription drug monitoring programs, and co-prescribing naloxone for overdose reversal. Balancing appropriate treatment of pain with minimization of opioid-related harm remains an ongoing challenge. Medication reconciliation is the process of creating an accurate, complete list of a patient's medications and comparing it across transitions of care to identify and resolve discrepancies. Unintentional changes in medications during hospital admission, transfer, or discharge contribute to adverse drug events. Systematic reconciliation at each transition helps ensure that intentional changes are communicated, while unintentional omissions or duplications are caught and corrected. Deprescribing has been mentioned in the context of geriatric care, but applies broadly to any situation where medication risks outweigh benefits. This might occur when a medication was appropriate initially, but circumstances have changed, when adverse effects emerge, when interactions with new medications create problems, or when goals of care shift toward comfort rather than disease modification. Deprescribing requires the same careful consideration as prescribing, including appropriate tapering to avoid withdrawal effects, monitoring for disease recurrence, and patient education about why stopping is beneficial. Therapeutic drug monitoring involves measuring drug concentrations in blood to guide dosing for medications, where the relationship between dose and concentration is unpredictable. The relationship between concentration and effect is clearer than between dose and effect, and the therapeutic index is narrow. Examples include aminoglycosides, vancomycin, anticonvulsants like phenytoin and valproate, immunosuppressants, lithium, and digoxin. Timing of blood sampling, interpretation of levels in clinical context, and appropriate dose adjustment based on pharmacokinetic principles are all essential for effective monitoring. The future of pharmacology holds tremendous promise. Precision medicine will increasingly tailor therapy to individual genetic, environmental, and lifestyle factors. Biologics, large molecule drugs, including monoclonal antibodies, proteins, and gene therapies, offer unprecedented specificity for molecular targets. Gene therapy may correct genetic defects underlying disease rather than treating symptoms. RNA-based therapeutics can silence disease-causing genes or restore function of missing proteins. Nanotechnology enables targeted drug delivery, concentrating medications at disease sites while minimizing systemic exposure. Artificial intelligence accelerates drug discovery, predicts drug interactions and adverse effects, and may eventually optimize individual patient regimens based on complex data integration impossible for humans to process. The microbiome's influence on drug metabolism, efficacy, and toxicity is increasingly recognized. Gut bacteria can metabolize drugs, produce metabolites that affect host physiology, and influence the expression of host drug metabolizing enzymes. Manipulating the microbiome through probiotics, prebiotics, or fecal transplantation may modulate drug response. This represents a frontier in pharmacology, acknowledging that human drug response is not solely determined by human genetics and physiology, but also by the trillions of microbial cells we host. Chronopharmacology recognizes that drug response varies with circadian rhythms. The expression and activity of drug metabolizing enzymes, transporters, and receptors fluctuates throughout the day. Administering drugs at times when receptors are most abundant or when disease processes are most active may enhance efficacy. Blood pressure typically dips during sleep and surges in early morning. Timing antihypertensives to blunt the morning surge may reduce cardiovascular events. Chemotherapy may be better tolerated and more effective when scheduled according to circadian rhythms of cell division and DNA repair. Understanding and exploiting these temporal patterns may optimize therapy. As we approach the completion of our exploration, we recognize that pharmacology is a living discipline, constantly evolving as new drugs are developed, new mechanisms understood, and new approaches to therapy emerge. The principles we have discussed provide a foundation that will endure even as specific drugs come and go, a way of thinking about how chemistry influences biology, how molecular interactions cascade into physiological changes, and how scientific understanding translates into therapeutic action. Throughout this journey, we have moved through autonomic pharmacology, where drugs mimic or block the chemical signals of the nervous system. Cardiovascular pharmacology, where vessels dilate and contract in response to molecular commands. Respiratory pharmacology, where airways open and inflammation subsides. CNS pharmacology, where neurotransmission is modulated to alter mood, cognition, and consciousness. Endocrine pharmacology, where hormones are supplemented or antagonized to restore metabolic balance. Antimicrobial pharmacology, where selectivity allows targeting of pathogens while sparing host. Oncologic pharmacology, where the challenge is distinguishing malignant from normal within a single organism, and through the special considerations of age, pregnancy, organ dysfunction, and genetic variation, we have seen that every drug is a key, shaped to fit specific locks in the molecular landscape of the body, and that turning these locks initiates cascades of events that ripple through interconnected systems in ways both intended and unexpected. We have learned that the dose makes the medicine or the poison, that pharmacokinetics determines whether a drug reaches its target in sufficient concentration for sufficient time, and that pharmacodynamics describes what happens when drug and target meet. We have explored how the body adapts to drugs through tolerance and dependence, how drugs interact with each other in complex ways, and how individual variation means that the same dose of the same drug can produce different effects in different people. The metaphors we have carried through this exploration of drugs as chemical conversations, of receptors as molecular locks, of the body as an integrated city where drugs travel like messages through communication networks. These are not mere literary devices, but genuine insights into the nature of pharmacology. Drugs do converse with the body in its own chemical language. Receptors do function as locks that drugs unlock. The body is an integrated system where local actions have distant consequences, where feedback loops maintain balance, and where intervention in one area reverberates through all. As you rest now in this present moment, perhaps more aware of the constant chemical activity within you, the neurotransmitters crossing synapses, the hormones traveling through blood, the ion channels opening and closing, the enzymes catalyzing reactions, you carry an understanding of how pharmacology works within this magnificent complexity. The same principles that govern how your body processes nutrients and regulates its functions govern how it processes and responds to medications. You are a living system of extraordinary sophistication, and pharmacology is the science of respectfully, carefully, precisely influencing that system toward health. The drugs we have discussed continue their work in countless individuals, lowering blood pressure gradually over weeks, suppressing immune systems to prevent rejection of transplanted organs, killing bacteria that would otherwise cause sepsis, stabilizing mood in those whose neurochemistry has strayed from balance, replacing hormones that bodies no longer produce. Each medication is a testament to human understanding of biology and chemistry, to decades of research and development, to clinical trials involving thousands of volunteers, and to the ongoing commitment to alleviate suffering through scientific knowledge applied with care. Pharmacology reminds us that healing is partnership. Drugs do not heal by themselves, but by enabling the body's own systems to restore balance, by removing obstacles to natural repair, by supplementing what is deficient, or by compensating for what has been lost. The prescriber brings knowledge of drugs and disease. The pharmacist brings expertise in formulation and interaction. The patient brings their individual biology and experience. And together, these create the therapeutic alliance that makes pharmacology effective. Rest in the knowledge that the chemical conversations occurring within you are part of an ancient evolutionary heritage refined over billions of years of life on Earth, and that pharmacology works because it speaks this ancient language, not perfectly, but well enough to make profound differences in human health and flourishing. The science continues to advance, new drugs are discovered, better understanding emerges, and the art of using chemicals to heal becomes ever more sophisticated. In the quietness of this moment, with the understanding we have built together, you can appreciate the elegant complexity of how substances interact with life, how molecules find their targets among trillions of others, how chemical bonds form and break to produce the effects we call therapeutic. You have journeyed through the landscape of pharmacology, from fundamental principles through major drug classes to special populations and future directions, building knowledge layer upon layer until the whole picture emerges. This knowledge does not burden, but enlightens, revealing the logic and beauty underlying medication use, transforming what might have seemed arbitrary into something comprehensible and coherent. The circulation continues. Your heart beats steadily. Your lungs exchange oxygen for carbon dioxide. Your neurons maintain their electrical gradients. Your cells carry out their metabolic tasks, all without conscious effort, all governed by the chemical principles we have explored. This is the context in which pharmacology operates, the living system that drugs seek to influence, always with the goal of supporting rather than replacing the body's inherent wisdom. As this exploration concludes, we return to where we began, to you in this present moment, breathing, existing, sustained by chemistry so complex and coordinated that we have only begun to understand it. Pharmacology is our attempt to work within this complexity, to guide it gently when it has gone astray, always with humility before the enormity of what we seek to influence. The field continues, the work goes on, knowledge accumulates, and healing advances, all built on the foundation of understanding how molecules interact with life to produce change.